My name is Jody Cook. I'm with Agilo Biotherapeutics. We are delighted to be here with you and sponsor this keynote session this morning. And I'm going to introduce to you Dr. Ron Thibert, which needs no introduction, as you all know. So he runs the Angelman Clinic in Mass General. He's a professor at Harvard, and he's extraordinary to everyone from everything I've heard. And we've gone over and met with him, so I will stop talking and turn it over to Ron.
Good morning. So I guess this is the first of like 3.5 hours that I'll be talking here this morning. So I guess it's time to get comfortable. So the keynote this morning is going to be Angelman syndrome in adulthood. So even though that's kind of the main gist, there's lots of stuff that's kind of pertinent to all ages. But as you'll see, what kind of the main thing is what happens to kids when they get older. And so we've got a lot of information about our current adults, but I think what we'll see is that as we go through all the slides and talk about things, I really think that the adults and those who are 3, 4, 5 now are going to look a lot different in 20 years than people do now. So it's kind of exciting. So Angelman in adulthood. So the first generation of kids were diagnosed in the 80s and 90s, and now those are the folks who are all kind of hitting adulthood now. And until recently, we really didn't have a lot of. Oh, jeez, it's been doing that all day. I don't know why. Let's see. Okay. But now we're finally starting to kind of look at it more, get some information, kind of see what we're seeing, what are the issues, how do things change, what's different when kids get older. So there's more and more, as I say, as people are getting older and more people are getting diagnosed, there's more adults, there's more teens. There's very little in the literature as far as what happens when people get older. And one of the big issues is that adult specialists typically don't have experience with Angelman syndrome or really any developmental disabilities at all. So that's kind of a bigger issue and something that really needs to kind of change over time. So our clinic at Mass General, for those of you that aren't familiar with it, we started back in 2008, and it's a multidisciplinary clinic. We have neurology and epilepsy, which is what I do, so I pretty much see everybody. And then as needed, we have specialists in psychiatry, neuropsychology, GI, sleep, and genetics. And there's also an adult program that we have. So there's an adult program with the Lurie Center for Autism at Mass General, which is our autism center, and they've had that for a few years now. And so there's already kind of a built-in kind of adult developmental disability program with an internist who's a specialist in developmental issues, and psychiatrists and GI doctors who see adults. So it's kind of a nice setup already kind of built into Mass General. So far, we've seen 170 people with Angelman syndrome over the years, and that's just different people. We see many, several times a year, so it's a lot of visits in general. But what we found was that 49 out of the 170 were born before 2000. So about 30% of our population now is 15, 16 or above. So it's as we go on, the percentage of older individuals is really kind of increasing. And the percentage beyond puberty just is bigger every year. So the first big study that we did, this came out in 2014. It was done 5 years ago, but we finally got it published in 2014. It was Anna Larson, who's worked with us and is now a resident at Mass General, did this over the course of a year and just put an amazing amount of time into it. She did 110 phone interviews with parents or caregivers of people with Angelman syndrome, ages 16 to 50. And the goal was to really kind of investigate the primary health issues as well as some of the social issues surrounding adults with Angelman syndrome. And so this is just kind of the basic breakdown of what we saw. About 38% were 16 to 20, so kind of more adolescent. But then 27% in the early 20s, 21% in the late 20s, then 15% 30 or above. Pretty even breakdown. Well, actually, very even breakdown of male and female. And then the genotypes were pretty standard distribution for Angelman syndrome. About 70% with deletions, 8%, 9% with UBE3A and UPD. So it's a really good representative sample of what we see. The majority were the patients' mothers. 89% had their moms do the talks, and another interesting little piece was that 75% are still living at home with their parents when we did that talk. And then we did a follow-up. So this is just brand new. We just did this about a month ago, but we went through all the records of people we see at Mass General. We just did everyone that was born before 2000, kind of made it a nice even cutoff. and went through the records to look at the same types of things: seizures, sleep, anxiety, myoclonus, GI issues, and just to really see, did that match what we saw in the survey study? What was different? What was the same? So, and I'm probably thinking, well, is it the same people? It's not the same people. So the survey was done through the ASF, so it was kind of national, international. We had families from all over the world respond to that one, but this was just the folks we see at Mass General. So it's when you add it all together, it's 160 different people, which is great. And again, the same kind of basic breakdown: half male, half female. A little more of the younger folks, 15 to 25, but still almost 20 people, 26 to 43, and the same pretty even breakdown of the genetic subtypes. So on to the epilepsy. So what Anna found when we did that first study was that that 60% of adults were seizure-free and 40% were still having seizures. And we'll talk about later is that seemed kind of high, and we kind of found out that it probably is high, and we figured out why. And with about 29% of them having 29% of the 40, so 3/4 of those having kind of monthly or less, so kind of less frequent seizures. And this was a breakdown of when people thought that their children's seizures were the worst. So 52% said in the first 5 years, 25% age 6 to 10, 12% age 11 to 15. And that's really what we see, and that's kind of just watching kids get older and watching them. That the seizures typically are their worst in early childhood, 3, 4, 5 range. That's they start, they're nasty, and then they get better, which is great. The interesting thing was that 6%, 5%, really the 20%, 31 and above. I don't know why this is doing this. It really wants me to join the Wi-Fi. So that was the other part that was not really kind of consistent with what we see. But we eventually figured out why too. We'll get into that. So in the second study that we did, just looking at our folks at Mass General, we found that there were only 28% that were still having seizures, with the majority either yearly or monthly. So rare seizures, and really only about 1/4 were still having them. So the number was much lower, which I think is a lot more accurate as to what we see. And these were the medicines that were, so in the, I'm kind of jump back and forth. When we did the survey study, the most commonly used medicine was valproic acid or Depakote, followed by clonazepam or Klonopin, and then lamotrigine is Lamictal, levetiracetam is Keppra, ethosuximide is Zerontin, and topiramate is Topamax. Those are the most commonly used medicines in the survey that we did. And then just to kind of compare that to another big survey that we did back in 2007, we did a survey, again through the Angelman Syndrome Foundation online, and it was great. We got 461 people responding. From the 86% had seizures, which is probably a little bit high, because when you do a seizure survey, you're going to get a little bit more people with seizures responding. So, but it's it's kind of in that neighborhood, with 60% having more than one seizure type, and specifically with the medicines. Again, same thing. Valproic acid or Depakote was the most commonly used, followed by clonazepam, and then actually the third most common was phenobarbital, followed by topiramate, and then carbamazepine, which is Tegretol. And what's really interesting about this is that phenobarbital and carbamazepine actually worsen seizures in Angelman syndrome. So we had a big chunk of kids that were on these medicines that not only don't really help, but they make things worse. So it was kind of eye-opening to see what people are using for medicines. And then when we did this, we kind of looked at whether epilepsy is refractory. So when we call epilepsy refractory, it's when 2 or more medicines don't work. And so turned out 77% of the people in that study were refractory, which really just doesn't match what we see. We actually have, I don't want to say it out loud and jinx it, but we have had pretty good luck controlling seizures in our clinic. So that seemed it was a little bit out of whack. So even though we got a lot of great data from that survey, it just didn't seem like it was quite. There were some things that just didn't really fit with what we were seeing. So one of the things we did was we went back. We did this just last year, and it's not quite published, but we're working on it. We went through all the records of not just the adults, but everybody that we see, to see what medicines are being used, how well they're working, all that kind of stuff. And we kind of narrowed it down just so that we had really good data. The people that we only saw once or twice, or the ones that we weren't actively managing their seizure meds, someone else was doing it. We kind of cut them out, and it was just the ones that we were really just clearly following and treating, and that we could really know what was going on. So that cut it down to 75. Although I think we're going to have more when we finally publish it. So again, the ones that were kind of most frequently that we had people on were valproic acid, levetiracetam, lamotrigine, and then clobazam, which is Onfi. And as we'll see, the ones on valproic acid, those of you that know me, those were not started by me. Those came to me on valproic acid. So, but what we found was, and the numbers are a little bit high, I think, just because they were often second medicines, third medicines, they were added to others. But we actually had response rates in the 80% range for levetiracetam, for lamotrigine, for clobazam. The LGIT is our diet therapy, which I'll talk about later. Also good response to that. So that, that 77% not responding, that 23% responding to the first two medicines didn't really match what we had seen. But when you think about it, if a big chunk of those kids are on phenobarbital or on tegretol, of course they're not going to get better. So I think those numbers are really skewed. When you look at medicines that we know work and that we put them on only medicines that work, we see much better response rates to seizures, which kind of makes sense. Use the right medicines, so you get better. So what we found, so I know, I always tell people this, and some people believe me, some people don't, but when you look at those four medicines, so we use a lot of Keppra, a lot of Lamictal, a lot of clobazam. The kids on valproic acid, we see a lot of side effects. In general, it's a medicine that has a lot of side effects, but I think for Angelman specifically, we see a ton of side effects. And what we saw, looking back at our records, was that 2/3 of the families endorsed pretty significant side effects. And the main ones that we all know are, weight gain, liver function issues, hormonal stuff for girls. But for Angelman syndrome, what we were seeing was increased tremor and actually decreased mobility. So a lot of motor issues. And when you think about it, you have children who have motor issues to start with. They're off balance, they're tremory, and you add a medicine which is known to cause tremor and worsen balance and all that. You can see where it really makes a difference. When we did that seizure survey in 2007, I don't know why I was doing this. So there were at least a half a dozen, maybe closer to 10 responses under the side effects section that said, we started Depakote and our kids stopped walking, and I thought that was really bizarre. I'd never heard of that before with Depakote. But in Angelman syndrome, that's really a thing, and we've had several kids, 8, 9, the oldest was 14, that never walked, that we stopped Depakote and they actually walked. So I think it has a lot more side effects than people realize, and not in general, but just in Angelman syndrome, I think it's really tough on motor skills. So looking back, we really saw that was an issue, and so that's one thing that we always try to kind of think about when we see Depakote. So kind of in general, the seizure survey that we did, in 2007, that was published in 2009, showed that the newer medicines like Keppra, Lamictal were just as good as Depakote and Klonopin in terms of how well they worked, but that they had less side effects in general. And then the one piece that wasn't really in the survey was clobazam. So clobazam wasn't approved in the U.S. till 2010, even though that we were using it through Canada for years and years. So there weren't a lot of people that were on it, so we don't really have a lot of data. But now that we do, we can see that it really is as effective as the others, and really one of my favorites for kids with Angelman. Then we looked at going back to the adult study that we just did last month. We can see that our adults, probably because I'm the one that's seeing them, they're on a lot more Lamictal and Keppra, and then less Depakote, and that just decreases over time. Also Onfi and clonazepam, which is Klonopin. So, kind of in summary, what we see is really that seizures decrease over time, which is great. They're kind of the most frequent, the most hard to control in younger kids, and then as they get closer to puberty, things really tend to slow down just naturally, which is great. What Anna found in the big survey study was that 40% of teens and adults were still having seizures. We found it was only 28%. But as we'll talk about in a minute, we think that's due to a non-epileptic kind of movement disorder, it's, myoclonus, so I'll talk about that in a little bit. But the big thing, too, in both studies was that about 2/3 of those that were still having seizures at that age were pretty rare. They were either monthly or yearly or less. So so even those that do continue to have some seizures, they're much less frequent. I think I already mentioned all this stuff, yeah. So I'll move on. So that kind of brings us to myoclonus, so the reason why the numbers were really different from the survey to what we see in clinic. So while we were doing that study, we noticed there were a lot of answers from parents of adults saying that, well, our children, they had seizures and they were fine, and the seizures came back, but they were these shaking events that would last minutes, they last hours, and it just didn't really kind of make sense. It didn't sound right, and started thinking about it more. And there were a couple of papers published in the 90s that were really at least one specifically that was really good, and I don't think anyone, it just kind of got buried in all the other literature, but kind of described these events and described them as non-epileptic, and it was that was really the only thing that we could find that was actually published, but it was really good. And so what we see is, when we see myoclonic seizures, and Angelman syndrome is one of the most common seizure types, and it's typical in young kids. It's often the first seizure type that we see. Real quick jerks. Some of you will probably fall asleep if you haven't already in this lecture. And when you fall asleep and you jerk and your head bobs back up, that's a myoclonic jerk. But we all have that in sleep, and it's totally normal. And kids with Angelman have a lot of that in their sleep, which is also normal. But when you have it wide awake, just walking around, that's not normal, and that's often what a myoclonic seizure looks like. So they're very brief. They last usually just a couple seconds. And if you have an EEG running when it happens, you see a big burst of spike and wave on the EEG. So that's how you know it's a seizure, not just some random movement for whatever reason. And there's a thing called myoclonic status. So I know we talk about non-convulsive status, and there's a variation called myoclonic status where you have that non-convulsive status where your EEG just gets really messy and skills kind of go downhill, but the kids are also really twitchy at the time. So that's myoclonic status, but the EEG is very, very abnormal, and what you see associated with that is a real decline in skills. So decreased speech, decreased balance, decreased communication, everything kind of goes awry when that happens. But what we're seeing in the teens and adults when it starts at age 13, at age 15, at age 20, is that the episodes can last seconds like the seizures, but they can also last hours. They can last 10 hours. They can last a day, and there's no alteration of consciousness. When we've seen people in the midst of these, and they eat, they drink, they play with their iPads while they're shaking. So it's not a seizure. If you're really having a seizure that long, you're going to see alteration of consciousness. You're going to see changes, and we don't see that. And what we actually did eventually was just because we were really struggling with a couple of our kids, we actually brought them in for monitoring and had the EEG running at the time, and the EEG showed no change. Actually, the EEGs were as normal Angelman EEGs, no epileptic activity. So that was kind of the final straw. So when we look back through our adults that were having this, 16 had so the breakdown 16 had deletions, 4 UBE3A. So we don't have any folks at the imprinting center, because I think we see 5 kids with imprinting center defects, and they're all young, so we don't know what happens in teenhood. But it was in all subtypes, kind of pretty well proportioned, and so we had those 2 kids, but there were also 6 others that came to us with EEG reports that said these were captured on EEG and were not epileptic. So at least 8 people now we have that information. What we saw was that 18 of the 45 people that at the time that we put all this information together had these episodes, these myoclonic episodes. 7 began in the 11 to 15 range, and 11 began in the 18 to 25 range. So kind of two different hot spots for when those start. All of the ones under 20 had just short events, whereas those who were 20 and up, 6 out of the 14 had events that would last more than an hour. So they tended to be longer in the older individuals. And then this is the kind of the breakdown by age. So in those that were 13 to 19, it was a little under 30%. 20 to 34, it was close to 50%, and then 35 and up was 50%. And it's hard to get a lot of information, because in the 35 and up there's only 4, so it's not like it's this giant 1,000-person cohort. But it seems like it does get a little bit more frequent as time goes on. So that always brings up the question: is it degenerative? Is the brain getting worse? Is it falling apart? Is it deteriorating? Because that's sometimes what myoclonus can do. But I think the answer is no. And I don't have great evidence, but the 4 people that we see that have this, that are 35 and up, they look fantastic. They're all walking and communicating. They look amazing. So I really don't think there's anything bad going on that's getting worse in their brains. I think we really think it's part of the movement disorder. In kids it's more tremor and balance, and I think in adults it's just more myoclonus. And so it's just the movement disorder changes over time is what I think. And so we'll see if that's what really happens or not. So the good news is, it's always a good news, bad news with these. So we always tell people, this good news, it's not seizure, it's not life-threatening, it's not dangerous, you don't have to worry about it. The bad news is it's not that easy to fix. So the standard medicines that we have that treat myoclonus, whether they're myoclonic seizures or sleep myoclonus, it's excessive, Keppra again, and then the whole benzo family, so clonazepam, clobazam, and then also like Ativan and Valium, diazepam, lorazepam. So that's usually our best bet, is a combination of Keppra and one of the benzos if they can tolerate it. Some of the other medicines that can help sometimes are Depakote, but then that brings in new and exciting movement issues, so we tend to avoid that. Zonegran can be helpful sometimes. We've had actually Vimpat help a little bit. So there are options, but it's not as easy to treat. So the good news is it's not dangerous. It's more of a quality of life issue than a real danger, but it's also not super easy to fix in some people. We've had some success. We've had, they see 30%, 20%, 40%. So I mean, some people really can improve. And the whole point, the whole kind of target for treating is just to improve quality of life. If they're not bothering people, then there's no point in treating it. When it gets in the way of eating and walking and just enjoying things, and that's when we really want to try to treat it. So that brings us to sleep, which is always a fun topic and that everybody enjoys. So sleep and Angelman syndrome. Sleep is, and we talked about this a little bit at the scientific meeting. Sleep is described in the diagnostic criteria. If you look at the 2005 diagnostic criteria, it's a diminished need for sleep in 20 to 80% of individuals. And I think when you look at kids who sleep 3 hours and they look happy and they're running around, they look like they don't need sleep, but in reality they do need sleep. We all need sleep. So and I know we see people that like feel guilty and they say, well, we want to get them to sleep because we want to sleep, but that's just a nice side benefit that you get to sleep. The kids really do need to sleep. We know that even if they look happy, if they're sleeping 3 hours a night, they're not going to have the same balance. They're not going to have the same communication. They're not going to have, the seizures will be worse. So I mean, sleep is really important. Even if they look happy and look like they're okay being awake for 5 hours a night, they're not. So that it's a big issue, and it really needs to be. I think it's one that's really under looked at. I don't know if that's the right word is, but it's. I don't think people really look at it enough and really realize its importance. But the better you sleep, the better everything else is. Development, communication, seizures, and even the myoclonus. Sleep deprivation. Sleep deprivation is I think it's a big trigger for the myoclonic episodes. And kind of going back to that, one of the best things that you can do to treat those is to get people to sleep, get them less constipated, and get them less anxious. It's easier said than done, but often fixing the other stuff, can help the myoclonus. And that's really the same for sleep too. So, we think the sleep problems are multifactorial. So we know that the GABA genes aren't expressed properly in Angelman syndrome. We know at the scientific convention we're talking about melatonin not being synthesized properly. So there's definitely biological reasons not to sleep, but there's also all sorts of other factors. So there's epilepsy. So if you're seizing a bunch, your EEG is not good. It's going to affect sleep. Certain seizure medicines can worsen sleep. So sometimes we're responsible for making the sleep worse. GI symptoms is a big thing. A lot of times, hear about bad sleep, and the story is, they lay down at night and they start crying and they wake up. That's usually reflux. So constipation, reflux, they can be huge issues in terms of making people not sleep. And then a big thing is anxiety, which we'll talk about later. But anxiety, I think, is there in all the kids, and it gets worse as kids get older. So. And that's one of the things when we're at the science convention, they have these real kind of designed experiments where they knock out this gene and knock out this gene, and they do these experiments. But in reality, the mice aren't constipated, they're not anxious, they're not. So it's it's when you look at it and how it really affects kids. There's such a big component to sleep. There's a biological piece to it, but there's also all this other stuff. There's medical stuff, there's anxiety, and there's a big behavioral component too. So in the terms of treating sleep, the first question I always ask before we start sleep meds is, is he pooping? Is he burping? Is he, so you got to make sure that the medical pieces are right. And there's a huge behavioral component. So one of the best things you can do for sleep, and I have a child who's a terrible sleeper, so it's easier said than done, but behavioral therapies to get kids to sleep. And it's not easy to do. I can speak from experience, but that's one of the most critical things you can do. But so really fixing the medical issues, working on behaviors, and then but still some kids, even with all that better, need medicines to help sleep, and so that's where those come in. Now the the information on sleep medicines is super limited. There's really not much out there. There's a couple of smaller studies on melatonin that shows that it's effective, and it is, and that's usually typically what we start first if we think that kind of everything else is as good as it can be. Other medicines that have been kind of useful anecdotally, trazodone, some of the benzodiazepines, gabapentin, and clonidine are medicines that have been used. And this is a table from the same survey that we did back in 2007, 2009. We did like kind of a sister paper to it on sleep, and found that 80% of people that responded to the survey had kids on sleep medicine at some point. The most common being melatonin, followed by Benadryl, clonidine, and trazodone. So when we looked at the adults specifically, and this was Anna's study back from 2010, 72% still endorsed some sleep problems. 22 were on melatonin, 25% were on other meds. But the average hours of sleep per night was 7.4, which is actually not that bad. It's not perfect, but it could be worse. Compared to, and this is the big thing, compared to infancy, 77% said it was improved, 6% said it was worse, so the majority thought that adult sleep was better than baby sleep. I think compared to childhood in general, it was pretty much the same. About 70% thought it was improved compared to childhood. So, when people say, does this ever get better? It does get better. It may not be perfect, but typically over time, sleep does, I think, just tend to improve on its own. But the best things you can do are like make sure all the other medical and psychological stuff is as best as it can be, work on behavioral techniques, and then as needed medicines. And so this is just some of the other stuff that Anna found. Trouble falling asleep, 65%, and trouble staying asleep. So it's not just falling asleep, it's staying asleep. It's kind of two different issues, and there's different medicines that help with those. But she found stuff like co-sleeping, 17%. So these are, co-sleeping is something that always leads to sleep issues. So that's something we always try to do. So it's not one of the behavioral techniques that's used. What was interesting was when we looked at our folks. The average hours of sleep was 7.96, so really close to what we found in the survey, and that's really the big thing from that slide. So, kind of in summary, compared to infancy and childhood, sleep was improved in about 75% of adults. That was in Anna's study, plus that's what we found as well in our folks that we treat. And then the average sleep time was really pretty close, 7.4 versus 7.96. Hours per night, so it's really nice when the data is consistent. You saw in the seizure data that we had a little bit of discrepancy, but that was because the myoclonus looks so much like seizure. A lot of people reporting myoclonus, but in the sleep section, what we got from the survey was really pretty similar to what we found in clinic. So moving on to GI, I kind of mentioned that a little bit before. Was GI. So these are some of the things that Anna found in the survey study. Excuse me. So lots of GI issues. So decreased satiety, poor hydration, which is really usually a behavioral thing. But 47% with reflux, 85% with constipation. So really a huge issue, very very common in everybody. And kind of going along with that increased satiety. 9% were underweight, but 22% were overweight and 10% was obese, mostly in women. So we don't know if there's a hormonal component to that or not, but most people are in that normal weight range, but they're about 30% are overweight and 10% are underweight. And then we did this study, so a lot of stuff that is almost published, so hopefully soon these will be available. We looked at GI issues in people we saw in clinic of all ages, and this was the first of hopefully more multiple studies that we do with our friends out of North Carolina. At the time, we had 120 people we were looking at. They had 43. The genetic breakdown was pretty similar in terms of, the deletions versus UPD. And found the same kind of numbers, 86.5% with GI symptoms, 72% had constipation, 44% had reflux, 10% had cyclic, so the other study said 37, said 10%, but still cyclic vomiting is a big issue. For the Mass General kids, we also had some endoscopy data, and we had 7 kids that had endoscopy and 4 were confirmed with eosinophilic esophagitis, so that's something that when there's these clear GI issues that just aren't getting better with anything, that's always something that the GI folks will do is biopsy and look for eosinophils. So it's basically an allergic response to something, and it's not always clear what that is, so they end up eliminating foods, but that's one of the things. By genetic subtype, we didn't see much of a difference. no matter what kind of genetic subtype, everybody was constipated, everybody was refluxy. The one thing that stood out was different was poor feeding as an infant was much more common in kids with deletions, and the only kids that required G-tubes were ones with deletions. So kind of as we know, kids with deletions are more affected in whatever area, whether it's seizures or sleep or development. But same thing with GI. You can have bad GI issues no matter what, but the kids with deletions were the ones that really severe, and there weren't that many. There were very few, but they had deletions. And the kids with deletions or UPD for whatever reason were the ones that had kind of odd swallowing issues, and those were the only ones that had the eosinophilic esophagitis. And then when we looked at our adults in the recent study, the numbers were really super similar. Reflux 54%, constipation 77%. So whether it was adults, all ages, survey, clinic data, it really all kind of says the same thing, that reflux and constipation are big issues. And just really, I think it kind of like sleep. It's a lot of people underestimate what effect that can have. Kind of a classic story is little guy will get super constipated, not poop for a week, and then because they're not pooping, they're not sleeping, and then because they're not sleeping, their seizures get worse, and so they have a bunch of seizures. So we give them Valium, and then the Valium makes them more constipated, and so it just kind of shows that how everything kind of works together. And when treating kids, it's easy just to get the phone call and they say, oh, the seizures are worse, but the question is why. And if you just treat with medicine, you're not really getting to the bottom of it. If the seizures are worse, why is it worse? And so it's not sleeping. You're not sleeping because they're constipated. So if you can go all the way back to the constipation, fix that, get the sleep better, then the seizures are going to get. I mean, it's not that you don't stop them with the Valium at the time, but a worsening of seizures isn't always a worsening of seizures. It could be a worsening of constipation or reflux, which sounds weird, but it's true. Sometimes we've had our best seizure control with Miralax, so you always have to ask why. It's not always okay. These are seizures. Treat the seizures. It could be other reasons. So that's always a key in treating kids is with developmental issues. And I know some of you probably know, but one of my daughters, my younger daughter, has autism, and so same thing. She doesn't have seizures, but she has GI issues. She has anxiety. She has sleep problems, and so we have the same thing at home. We always have to figure out, okay, why is she awake at 2? Like, is she worried? Does she need to poop? So we do it at home too. So it's always a puzzle, and if you don't look at everything, then you're gonna miss what's going on. So orthopedics and mobility is something that people don't always think about, but is it's always something to look at. One of the big things is scoliosis. When you think orthopedics, think scoliosis. There's other stuff, but that's a biggie. We found that 50% in the survey that we did had scoliosis. Most of it mild, but still a pretty fair amount of scoliosis. Osteopenia was a big one, 16%. So that's when your bones get real thin, and it's kind of like osteoporosis, but it's a little bit different. But it's and that can lead to increased fractures. So when your bones are thin, you're more risk to get fractures. And what she found was that 68% of adults were walked independently, and another 22% walked with just some assist. And just some more mobility data. I'll kind of skip through that. What we found was that only about 29% had scoliosis, so a little bit less, but still, a decent amount with scoliosis. And the other numbers were really strikingly similar too. The clinic data matching the survey data, 20% with low bone density, and 65% walking independently. And really, I'll probably talk about this at the end, but as far as this is one of the things where I think, where I said before, where adults in 20 years are going to look different than adults do now. I think, a lot of the seizure medicines that, someone who's 30 now was probably on phenobarbital, on Tegretol, because the fancy medicines weren't out until the 90s. So the medicines that we use so much now came out in 95, clobazam just recently. But a lot of the older medicines will kind of worsen bone health. So that's one thing, is, being on the right seizure medicines. I think now we have a lot better PTOT. So even So I mean, I think this is a big thing. I think if we look at this again in 20 years and see what percentage of adults are walking on their own, I bet it's going to be much higher than 68%. And you never know too. You think about something like Depakote. How many of those adults have been on Depakote 20 years and they're not walking because of it. So I think using the right seizure medicines, using medicines that don't have a lot of bone issues, and really more aggressive therapy, which I think a lot more people are getting a lot more therapy these days. I think you're going to see a big change. So even without, hopefully the therapeutics end up working out and helping people, but even if they don't, I think there's still a lot of hope for the future with just doing things better than we do it now. So challenging behavior. So this gets into a tricky area. So in the survey, we found that 72% were aggressive towards others, 52% were self-injurious, 48% were obsessive. So all sorts of 47% seemed frustrated. So lots of behaviors. These are some of the common ones: pulling hair, hitting, yelling, dropping to the floor, hugging too tightly. These probably sound familiar. Chewing, pinching. Probably look very familiar. And in the survey, 46% felt that their children were anxious, whereas only 10% thought that they might be depressed. And so what we see is in adults is that, and so we don't have good data. We have a little bit of data, but not much. We think that more adults than not have clinical signs of anxiety, and I think I would say probably most, but to different levels. But some can be super severe, and what's interesting is the way it presents. Sometimes, it's not always doesn't always look like the classic anxiety. It's sometimes it really is. It's really clinging to their mother. I mean, we see that a ton. Like just mom can't leave the room. That's a big one. But we've had people that have refused to leave the house. They refuse to leave the car. And we've had a few, at least 3 or 4 adults who just excessive swallowing and vomiting. They get so anxious, they just start swallowing and they just start vomiting, and they can vomit for a day or 2 days. And we've actually, did the GI workup, did the scopes, did the whole thing, and it turns out we put them on Valium or and they got better. So it can really present when you can't speak. Your anxiety can really come out in a whole bunch of different ways. So it's something that you don't always think of first, but it's we figured out by just process of elimination, nothing else worked. Is it anxiety? But now that we've seen that, it's kind of easier to recognize, and it's I think in adults it's probably the biggest issue that we get called for, that we see people for, is behavior and anxiety. What we found was that we thought that at least 55% of our adults clearly had anxiety. I'm sure it was more, but the ones that we just said, yes, this is anxiety. 24% had impulsiveness or aggressiveness, and another 12% with the defiant behavior. And I think that's a tricky part too, is a lot of times kids will get aggressive when they're anxious. And so often, and especially like in the autism population, the medicines that work best are Risperdal and Abilify, the antipsychotics. So those actually have FDA approvals for agitation and aggression in autism. But Angelman syndrome is different, and I don't think the kids with Angelman syndrome are agitated or aggressive just because. I think they are because something's bugging them. So I think at times that behavior is pain, their belly hurts, their head hurts, something's bugging them, or more commonly it's probably anxiety. So treating aggression with an antipsychotic usually doesn't. I mean, it'll sedate them, so they'll stop being less aggressive, but that's not really the answer. It's getting to the root of it and really helping the anxiety so that they stop being aggressive, not just kind of knocking them out with like a Risperdal. So kind of in summary, in general, in Angelman syndrome, we see 80-90% of children have seizures. But what we're seeing as they go on, they improve as time goes on. As kids get older, they get better. As they get better towards puberty, and in adults, I think the newer data we're looking is probably more accurate, where about 25 or 30% of adults still have seizures, but the ones that do, the majority are pretty rare. They're monthly, they're yearly, so it's not that kind of frantic 2 medicines, 3 medicines, just going crazy. Those real tough seizures we see in young kids, we don't see in adults. So that's one thing that definitely gets better. Sleep improves in 75% of adults compared to childhood. So the average length of sleep, 7.4 to 7.9 hours, which is not bad. So I think even though it biologically improves with increased anxiety, that may be the one thing that's really kind of holding some of the adults back. So that's where that mix of behavior and medicine really kind of fits in. But seizures tend to get better. Sleep tends to look a little bit better. GI symptoms, they don't worsen, but they don't really get better. They're just there. They're always there. So always something to watch, always something to treat. And they come and go. It's not like you have constipation. You always have constipation. There's that there's different medicines. There's also diet changes. Again, easier said than done. But increased fluids are always helpful. And then there's also different kind of poop type foods that you can use. Coconut oil, avocados. There's different things that you can do. But most kids, some kids just get better with diet changes, but some need diet changes and medicine. But even though it doesn't seem like it's a big issue, really, kind of uncontrolled GI symptoms will worsen sleep, they'll worsen anxiety, they'll actually worsen the myoclonus, which sounds crazy, but it's true. And they can worsen seizures, so it's definitely something not to underestimate. Orthopedics and mobility, so scoliosis 30 to 50%, osteoporosis in 16 to 20. Like I said, 65 to 68% were ambulatory, but I think that's just going to get better over time. I think a lot of that is the drugs that were available to the current adults. I think newer, better medications. You're going to see more ambulation. You're going to see better bone health, and you're going to see more. You're going to see less scoliosis too. One of the best. Not one of the best thing for bone health is ambulation. If you're up and you're walking, your bones are going to develop healthier. So that's a big thing. The non-epileptic myoclonus is kind of new. We haven't published that yet, but the moment we do that, it's probably going to be the first thing that's really out there. But these events in adulthood that we're seeing, we really they're common. They're very common, and they're tough. Like I said, the good news, I really do believe they're non-epileptic. I'm actually convinced they're non-epileptic. So, it's part of the movement disorder. And like I said, I don't think it's degenerative. We see a lot of disorders in neurology that they are degenerative. The brain kind of shrinks down. It gets worse. You see myoclonus associated with it. But I don't think that's. I think this is just pure movement disorder. I don't think it's anything getting worse because the folks we see that are older that have this, they look awesome. So there's nothing degenerating in those folks. But I do think it's kind of, as we try to understand the movement disorders better, the ataxia, we know the imbalance, the tremor. I think this is just part of that spectrum, and it's just it's what happens as you get older. So it's not dangerous, it's not life-threatening, but it is a quality of life issue. It's not fun. It really kind of for some people it really kind of prevents them from what they want to do. So when it interferes is when we treat, and then that's been mixed. We're still trying to figure out how best to do that, but we've had pretty good luck with most. But sometimes it's tough. It's not movement disorders are never easy to treat, but we try. And then the last piece is anxiety, which I think is present in all ages, but especially gets worse with it. But if you look at, I have a 13-year-old and she's she's anxious. So it's not just kids with Angelman. It's all humans. They get anxious as they get older. Puberty hits. It's an awful time to be a teenager. But But I think when you can't speak, and I think Angelman is really unique in that kids understand so much and they know so much and they're so sharp but they can't get the words out. It's really frustrating. I think that frustration is a big part of the anxiety too. So I think another big thing is all the augmentative communication stuff, all the literacy stuff. I think that's going to make a huge difference for anxiety because the better kids can express themselves, the less anxious they're going to be. So even beyond medicine, I think that's probably the best thing we can do for anxiety is to get them telling us what's going on. It's not going to fix it. They're still going through puberty. They're still going to be teenagers, but it'll help. It'll help for sure. I think that's it. I saved a little bit of time for questions. Obviously, a big thanks to Anna Larson who did all that work for us, and then the other folks with the seizure survey. The Pritzker family was a big help with that. Jane Summers helped us with the original questionnaire. Eileen, obviously, in the foundation. All the parents that participated in the study, and then the folks at the bottom, Sarah and Laura, helped us with the GI stuff and the myoclonus stuff. And Keita was the one that did the just the adult study last month, and then Portia Kuntz from Ben's lab in North Carolina. She was the one that did a lot of the GI work from North Carolina. So I think that's everybody, and I think that's it. Thanks.
Hello.
Hey.
I always feel sort of out in the wilderness at these conferences because I heard this the last conference I went to, that our kids tend to outgrow seizures, and my daughter's 26, and her seizures became life-threatening at puberty. And, I don't, she had stiffness. She wasn't interacting. Her eyes were, jerking. I mean, I know they were seizures. Her neurologist knew they were seizures. And I keep getting told, and other parents of younger kids keep getting told they'll outgrow them. And she didn't. And we went through every medication. And finally, at the last one, it went on for 13 minutes. I was met at the hospital by the chaplain. And then finally, she got a VNS. And that was about 12 years ago. So my question is now, I mean, our neurologist has a very low threshold. I mean, basically, his feeling is she's not dying, so let's not change anything. But she's on Depakote, and I've heard so many bad things about it because she doesn't walk. She's never walked. Right before the seizures recurred in puberty, she took 47 steps independently. She'd been seizure-free for like 6 years. They were really bad, and like everybody's at like 2, 3 years old. But once we found the right drug combination, they were totally controlled. And so she's never, she walks with, one arm support, but, she leans real heavily, and I mean, she uses a walker and all that. But I can't help but wonder if she weren't on Depakote, if her balance would be better. So I'm wondering, how do you wean somebody off a drug that she's been on? Because she has a VNS and Depakote to control the seizures and Klonopin.
Yeah. No, it's a great question. And that always comes up in adults, whether they're still having seizures, not having seizures, is when do you come off, when do you change? And it's never easy. So for Depakote, I usually try to get people off it because other things tend to get better. If it's the one medicine that ever worked, that's a different story. You don't want to come off something, but
Onfi I don't think was out because she's 26.
Yeah, Onfi's only been out for a couple of years.
Yeah.
But just in general, it's tough. Like especially we've had people that have been on Transine, which nobody uses anymore, but for like 20 years, and what do we do with it? So in some cases with the benzos, with the Klonopin, we've taken some adults off. We've weaned them slowly over time, and then we saw a bunch of stuff get better. Behaviors get better. We've seen like balance get better. So I'm so glad we did that. And others we've taken them off their 20 years of benzos, and they've just been disastrous. Like this behavior went just through the roof. They were miserable. We put them back on. Some people were on and it was crazy. There's someone's like 1/8 of a milligram of like just this tiny dose of Klonopin. It's like, oh, you're not going to need that, and she needed it. So it's you never know. I mean,
yeah, we did try to wean Klonopin once.
Sometimes
we just recently tried to wean her off Risperdal, but
miserable.
that was a disaster too.
Yeah, Risperdal's another one that really affects movement and balance. So the combination of Depakote and Risperdal is we do see a fair amount of people on it, and it's probably the most sedating, kind of ambulation ruining kind of combination that we have.
It wasn't Risperdal. I'm sorry, it was Invega, but it's the same family.
Same concept. Yeah. But at the best what we always do is we look at the risks and benefits, and if the risk of seizures coming off the medicine is really big, then it may be something that you don't want to do. But if the risk you don't think is that big, it could be worth it. So we always, when I see people, I always try to gauge what good is going to come of this, what bad is going to come of this, and if we think there's more good than bad, we give it a shot, and often it works, and sometimes it doesn't, and we say, okay, that didn't work, and we go back to the drawing board. But that's always the best thing you do is just, okay, what could get worse if we do this? What could get better? And if the positives really tend to outweigh that, it's worth a shot. That's what we do for all the kind of all these med decisions, and especially in adults, because been on it 20 years, you don't know what's going to happen, and honestly, some of the people, we take them off these meds after years and years, and they get so much better, and we're so happy we did it. And then some, they kind of go nuts, and then we put it back on. But it's it's one of the things you don't know until you try. But I think it sounds like the Depakote and the Invega really are affecting the ambulation. But then the question is, what's the risk of seizure? But but if you haven't tried some of the newer, better medicines, they can really be amazing for some people. So
especially it's been about 11 or 12 years. I would just caution you as a scientist from making blanket statements like that, because I know I'm not alone. I've connected with other parents of adult angels online who also, they recurred in puberty and they were bad.
Yeah.
And
but it wasn't a blanket statement though. It was most people get better, which is true. But
okay, I think you said don't worry about it. But
but if you look at the data that we had, about 30% still have seizures, and about 10% of those they're still frequent. They're still tough. So it still happens.
Okay.
Yeah, yeah.
Mine was a similar question. My son's on, he's 20, Zonegran, and he hasn't had a seizure in 10, 15 years, really, and benzos. Based on what I've heard, I want to keep him on the benzo, Klonopin, but Zonegran you didn't even mention, and so his neurologist is like, well...
Yeah, no, it's a good question. So the medicines that I mentioned are just the ones that we use the most, and they're effective, and they tend to have less side effects. But there's still a bunch of other medicines that can be helpful. So Zonegran, Topamax, Banzel, Vimpat. There's other medicines that can help and do help. And so Zonegran is something that there's always that risk of kidney stones and of acidosis. So you have to kind of keep an eye on that. But it's the same concept. If the risk of coming off is high of seizures, you leave it on. If it's been years and years and you want to give it a try coming off, it's just you have to outweigh the pros and cons. Yeah.
Do you see any walking issues with Sarantin?
Not that I know of specifically, but you can never say never. Like Onfi is probably my favorite medicine for kids with Angelman, and it tends to help anxiety, it tends to help sleep, but it can make the occasional kid manic. It can make someone off balance. So any medicine that affects the brain can do strange things. So that's not a known side effect of Sarantin, but nothing's impossible with seizure meds.
Yeah, we found he was on 250 milligrams of Sarantin 3 times a day and just not walking well, unwilling to walk, and slowly discontinued it, and he was like the ever-ready bunny, but then seizures came back, so we had to kind of reintroduce it. My second question is, I think we have an issue of the non-epileptic myoclonus, but it's much more involved than what you're describing. In fact, we have to get the paramedics in, take him by ambulance. Yeah. We're giving Diastat, and it is potentially life-threatening because it involves the whole body, the breathing, the perspiring. And our home remedy is Diastat, and then we give Mativan in the hospital. Any other suggestions? And he is on, I corresponded with you, he is on propranolol to kind of tamper those down. That helps a little bit. Yeah. For a little while, we were working with a homeopathic doctor who had a compounded naltrexone. That seemed to work for a little bit, but nothing is 100%.
Yeah, no, that's the best thing that we have are the benzos, and so if one doesn't work, we try another one. So if Diastat's not cutting it, we'll try Ativan. Klonopin can be given. So we just try to get the best cocktail of benzos, and then for the ones that we have that are really tough like that, it's really about trying to get to the root of it, and it's not easy. But a lot of the kids that we see that have the super tough ones that do end up in the ER sometimes because they can't be controlled. They have awful GI issues. They have terrible sleepers. So and I think it's easier said than done. But really getting to what's triggering them, what's causing them, because I really do think that definitely some will have them worse than others, but the ones that have them really bad, I do think there's something triggering them, whether it's anxiety, whether it's GI, whether it's sleep, whether it's all of the above. And the more you can get to those underlying issues, the less you're going to need to use the rescue medicine. So like I said, it's easier to say it than to do it. But
thank you.
Yeah.
Hi, Siobhan from Boston.
Yeah. It's nice to meet you.
Yeah. I was wondering if you could speak a little bit more about cyclic vomiting, what distinguishes it, what characterizes it, what makes it specifically that, and then also, how much of it is GI, how much of it is neurological, and maybe also if you could speak a little bit about treatment and maybe even preventative options.
Yeah, that's a great question. So I mentioned just a little bit cyclic vomiting, and I wish I had the answer, but just in the neurology world in general, it's still not super well understood. It's still not something we know. We know that actually my daughter, on top of all other stuff, she was a cyclic vomiter, but she responded to Prevacid. So one of the things, first thing you always think of is it just bad reflux, and some kids with bad reflux will get the cyclic vomiting syndrome, and so it's often a first line, you treat the reflux. Often that doesn't work, so you move on to the next step. And in some of these adults, definitely it's anxiety. So I think definitely in a lot of the kids, teens, and adults with Angelman syndrome, if you treat reflux and anxiety, the cyclic vomiting will stop. So I think those are the biggies. But then there's a small percentage of kids in general, and I assume that kids with Angelman are going to be in that group, where it's almost like a migraine type phenomenon. And so, you look for underlying reflux, you treat it, you get anxiety as, decrease as best you can. Again, easier said than done. But then for those that just don't respond to anything, is it more of a migraine syndrome? So you think about stuff like propranolol, stuff like amitriptyline, Topamax, which is also seizure medicine, can be helpful. So it can be any one of the three, and it's and kids with cyclic vomiting, some respond just to anxiety meds alone, some respond just to GI meds alone, and then some, we end up going into the migraine types, and sometimes it's all of them. But it's a great question. It's not something we understand well, but we know that those three things at least are part of it, and that's typically what we target. Yeah, sure.
Hi, I'm Maria Sayer from Chico, California.
Oh.
And sorry, I came up first, sorry.
No.
So my daughter is 16. She was had her first seizure at 4, was put on Depakote, stayed on Depakote seizure-free until approximately 2011. We took her down to see Dr. Hutchinson, who is with the UCSF and knew a lot about Angelman's. He took her off the Depakote. Well, he weaned her off the Depakote, changed her to zonisamide. We went off the Depakote to just straight zonisamide for about a year and a half. Then she started having seizures again, which now I'm understanding more might have been myoclonus. Then we also started her at that point on seasonal for birth control. Actually, quote unquote, period control.
Right. Yeah, absolutely.
Because nobody wants to deal with that.
Nope.
And so when we took her back down to see Dr. Chitness, who is out of Sutter Memorial in Sacramento, she put her on the Onfi, which she's been really had good reactions with. So now she's on the 100 of zonisamide, 10 of Onfi, and then she's on the seasonal. So my question for you is, what is your thought process on combining a birth control medication with seizure meds? Because I've heard conflicting information that birth control can actually increase the seizures.
Yeah, no, it's a great question. It's possible, but in general, birth control pills are usually helpful for seizures. So one of the big triggers, and not just in Angelman syndrome, but epilepsy in general, which is kind of my day job, and as an epilepsy doctor, we often see that. Girls, especially girls, but only girls, when they start having their periods, when puberty hits, mostly in girls, but only in girls when they start having their periods. That
Boys have them too, just differently.
Yeah, no, I know they do. They, exactly, but that's often a big time where seizures worsen, and I follow a decent amount of teenage girls who. They only have seizures when their periods hit, and so one of the best things that we can do is actually put them on birth control pills. So there's a couple minor interactions. It can birth control pills and Lamictal can kind of lower each other's helpfulness, but you can kind of get around that. Depakote maybe a little bit, but really, especially we would call it catamenial when it's the seizures are with the periods. But regulating hormones can really be a big help for seizures. So if it's helping or not hurting and it's doing its other jobs, and it's totally fine. Yeah.
Okay, perfect. Thank you.
Yeah.
Hi, I've got more of an observation and a comment rather than a question. I think with this group of people, parents of adult Angelmans, they've had lots and lots of carers in their children's lives, and I'm interested in the comments made in this conference so far about the highlighting the anxiety symptoms of children, and I just would like your comments on the fact that as we're reaching adulthood now, for instance, my son would have had in excess of 500 carers in his life, even though he lives at home, and so I would just encourage all my fellow Angelman parents to insist on continuity of care for their children in day programs, because I think obviously continuity of care is going to reduce anxiety, and although the medical evidence is coming out about anxiety, and I will take that away and consider medication, I would like to be able to put that advice about medication in perspective with the problems that we all experience about continuity of care. Yeah. And of course somebody's going to exhibit great signs of anxiety if they've had 500 to 600 people in their lives.
Yeah, no, that's an amazing point, and I didn't put everything in the talk, but what we've actually seen some adults, when their caregivers change, especially if there's a big turnover, that their myoclonus picks up. So, they'll be doing fine, their myoclonus picks up. We say, well, anything going on? No, nothing's going on. Well, we changed our caregiver. It's like, well, that's what's going on. But that's a big source of stress. And the kids love their routines, whether they have Angelman syndrome, don't have Angelman syndrome, or they have autism, and routine gets broken. That's a big stressor. And so, and that's a big part of the routine is the caregivers. So that's really a fantastic point. Yeah, absolutely.
I have
I think I'm being
two
cut
real
off.
quick questions. Yeah. As far as anxiety, my son's on Tenix, and I'm wondering if it's helping or not. I really don't see a lot of help with it. And then also, can you comment on CBD oil for seizure control?
It's a good question. So sometimes as a first-line anxiety kind of medicine, 10X, which is guanfacine or clonidine, can be used, and those are good, safe, easy first-line medicines. So sometimes they help, sometimes they don't, but there's never a downside to trying them. They're actually old blood pressure medicines that don't really affect blood pressure that much, but they kind of help take the edge off of things. And then CBD is cannabinoids, which is medical marijuana. It's actually a very promising treatment for seizures. So it's available in Colorado, a little bit in California, but Washington. There you go. So it's popping up all over the place now. But there are big studies going on around the country now. Actually, we're one of the sites, but they're multi-center trials. Initially, there was like an open study, but then they're looking at specific Lennox-Gastaut, Dravet, other types of things, and the results aren't out, but it seems really promising, and it's a treatment that has very little downside. It's it's a plant, but they take out the THC, which is the part that gets people high. So it's just the cannabinoids that nobody really wants, and they mix it in oil, and it's not. I know when that Charlotte's Web came out, people thought it was going to cure everybody. It was the magic drug, and it's not. Like, there's no such thing as a magic drug at the moment. But it's another option that can be helpful where others aren't. So it's although we don't have a lot of data now, it's very promising, I think. I'm really curious to see how it goes. And I think I have to one final one, then we'll stop. Last one. I'm here all day.
So my daughter has been on Depakote for 4 years or so, and she's been seizure-free for a long time until recently, like maybe 2 months ago. I think it had to do with her bad sleep patterns. And you made a couple of remarks about the side effects of Depakote, I believe, in your talk. With regards to movement, could you elaborate a little bit on that and give me a recommendation whether we should think about weaning her off or?
Yeah. Well, as far as the movement, so we tend to see Depakote causes more tremor, more balance issues, more ambulation, and but again, nothing is 100%. It's it's like and the slide says 66% had side effects. So there are kids who are on Depakote and are side effect free. So in terms of like I said before, you always have to weigh the risks and the benefits. If you're on Depakote and movement-wise things are going well and the seizures are good, there's really no reason to come off. It's a medicine that I usually don't start because there's more chance of side effects, and the ones I take off because I think they're having movement issues or they're having decreased balance. We don't just do it randomly, so it's always that plus minus. I mean, like I said, there was 9% were still on it, and it's because they were on it and they weren't having side effects and they were seizure free. So you don't mess with success. So it's like anything, it tends to have side effects, but some people do fine on it. So it's just it's something to think about. If you're on it and you're having issues, that could be why. But if you're not having issues, then we don't rock the boat if things are good.
Thank you.
Yeah. Thanks.